that you have with pneumonia that is hospital acquired, let it be VAP or let it be hospital acquired pneumonia that is without an endotracheal tube, is the problem of overdiagnosis, over investigations, underdiagnosis, and under investigations. Everything is a problem. Okay. Importantly, what you must understand is when you diagnose VAP in a patient, no, it is only 60% of the times that you're right. It is only 60% of the times you're right. So, because now if you think VAP, you will start thinking multi-drug resistant organisms. If you start thinking VAP, the thinking will be multi-drug resistant organisms. Right? This is what your thinking would be. Am I dealing with multi-drug resistant organisms? Because needless to say, this patient will be on an antibiotic, then you have intubated, then he's developed a VAP. So the chances of having a multi-drug resistant organisms always comes in your mind, and then you overtreat. So you overdiagnose and you overtreat. Okay, so the problem is overdiagnosis and a classical overtreatment. This is our problem, overdiagnosis, overtreatment, and that is why, as doctors in the ICU, the first thing is to achieve the right diagnosis. The first thing is to achieve the right diagnosis. This is very, very important. Achieving the right diagnosis becomes extremely important when you're dealing with any kind of pneumonia that is hospital acquired, right? So in the event that you want to diagnose a patient with ventilator associated pneumonia per se, for hospital acquired pneumonia, why is it so difficult? Because of the fact that it is not necessary that a person's WBC count being high means that there is pneumonia. Leukocytosis has multiple reasons. Okay, it is hardly 50% sensitive. Today, if you have a patient who is having a chest pain, also you'll have a WBC count that is elevated. A person who's just had a little bit inflammation also have a WBC to be elevated. That's not pneumonia. Are you understanding? So the presence of a WBC count going high is in no way indicative of a pneumonia. The presence of a fever on its own is no way indicator of a pneumonia. The presence of a procalcitonin going up is of no use saying that this is a pneumonia. So in short, it is just not possible to diagnose a ventilator associated pneumonia based on a WBC count. For example, you have a patient on the ventilator, today WBC count is 10,000, tomorrow is 15,000, that doesn't mean it is pneumonia. You understand? So the question comes, how do you diagnose pneumonia? So there are three criteria where you put it into pneumonia. Okay, there are three criteria. Which are the three criteria you think about whenever you want to think of pneumonia? You will have one as a radiological criteria. Okay, you will have one as a radiological criteria. The second, anyone? Second will be a clinical criteria. Okay, clinical criteria, and the last would be microbiological criteria. So you have, so as I told you, just the presence of a WBC count going up does not mean it is pneumonia. Just the presence of a patch in the lung does not mean it is ventilator associated pneumonia, because very often our patients are all hypostatic. Our ultrasounds are useless to diagnose a pneumonia in our ICU patients after a couple of days. Why? Why is our ultrasound atelectasis? We are not living to sleep. We are all living to walk. We are built to walk. What are we doing over here? We are making all our patients right the opposite, making them sleep. We are allowed to sleep only for 8 hours in a day, 10 hours, not more than that. Tomorrow, if I sleep for 24 and 48 hours, I will develop atelectasis. I will develop hypostasis. So what you see as comet, what you see as whatever you see in the ultrasounds as B lines and things like that, is going to be an occurrence in 90% of your cases who are in the ICU. Are you understanding? So by looking at an ultrasound and saying I can see something, you cannot diagnose pneumonia. Are you understanding? Similarly, the same situation with the chest X-ray. So today, if I take a patient on the lying down for 2 or 3 days, and I do a chest X-ray, my diaphragm will get silhouetted. I will see some amount of patchy consolidations on the left side, right side, because of the fact that he is hypostatic. So you cannot say for certain that this is pneumonia. You can't say for certain. It could be pneumonia, could not be pneumonia, could be atelectasis, could not be atelectasis. So that's why the X-ray per se is also not a great choice when you look at pneumonia. And that is primarily the reason that you have to use a combination of a radiological experience, because it is very less sensitive in the first place, add a clinical knowledge to that, and then you add a microbiology to that. Only then can you diagnose ventilator associated pneumonia. Am I clear till now? Clear? So your diagnosis per se has to have all these parameters. So when I say radiology, what am I looking at? I am looking at a chest X-ray which is progressive and persistent, new or progressive and persistent. Okay, so the answer is new or progressive, persistent, infiltrate, cavitation, consolidation, that is there. It should be new or progressive persistent. This is important to understand, progressive persistent. Matlab, if you have a patient who already has, say, an atelectasis, because this patient may have an atelectasis, the patient may already have something on the lung, it has to progress. It has to progress. You cannot have an X-ray that shows patch, I put on the ventilator, patch, this is not ventilator associated pneumonia. Okay, I have a patch, I put on the ventilator, and 2 days later this patch has become big. That is ventilator associated pneumonia. Are you understanding? Am I clear on this? Or I had a chest X-ray that was normal, I intubated this patient, 48 hours later I found this patient to have a new patch that has come in. So that is one criteria that is going towards ventilator associated pneumonia. Mind you, this is only one criteria. Okay, so it is mandatory. That is why an ultrasound becomes mandatory to you every single day on a patient on the ventilator. Every single day. Because what will happen with the ultrasound? When you are doing an ultrasound, you will notice something that is wrong. You will notice something. Yesterday I have done an ultrasound, it showed some amount of atelectasis in the right side, and now you are doing an ultrasound, it shows more on the left side and something that is increasing there. Okay, on the right side too. Now you think, okay, let me do a chest X-ray. You understand? So it is mandatory to do an ultrasound in every patient that is on the ventilator, because it's the easiest tool for you to decide to do an X-ray chest. Doing a daily X-ray chest is said to be not very great. We don't want to do daily X-rays. Why? Because you move the patient. Every time you are moving the patient, there is going to be a chance of tube removal, there is going to be a chance of problems that are occurring. We don't want to do. We want to do it only and only when we think that we are going to get something in this. That is why the most simple non-invasive test that you can do is sonography. Right? So that is why what do we do when we are doing our rounds? Every single day we are looking at the ultrasound of every patient. This is what we should do. Every patient we do the ultrasound and we see what we are looking at. Because if you have a new, progressive or persistent infiltrate, we are looking towards probable pneumonia as a radiological diagnosis. Probable. Okay, we are not even sure till now. Okay, clear on this till now? Am I clear on the radiology till now? So the words are new or progressive, persistent. It has to be progressive and persistent or new. These are the words. So when you talk about X-ray findings in ventilator associated pneumonia, you don't say I find consolidation, I found patch, ऐसा नहीं होता है. New, progressive, persistent infiltrate, consolidation or cavitation. This is what you are supposed to talk. Clear? These words are very clear, very important words. These are very, very important words. Okay. Now, when you come to clinical findings. So what do you think the clinical findings should be? So the first, let's break it down. You break it down into what is the inflammatory findings. Okay, so you will break it down into what is the inflammatory findings. So at least one inflammatory finding should be there, which includes, tell me what could be the inflammatory findings, Ashok? Fever. So fever. Okay, fever more than 38 degrees. Okay, fever more than 38 degrees. It is not 38.3. That normally called as ICU fever is 38.3. But in ventilators or pneumonia, we are even considering fever more than 38 degrees. You understand? हम लोग normally क्या बोलते हैं ICU fever. When I say ICU fever, it means that fever that will make you start looking for further investigations, make you do further investigations. That fever usually in the ICU is 38.3 degrees. However, for the diagnosis of ventilator-associated pneumonia, that is 38 degrees. Right? 38 degrees of temperature is what you're looking at as fever. Then, what do you think should be there? Other categories for inflammation. Come on, fever हो गया, then that is not inflammation. WBCs. This is WBCs now come here because we said WBC is not pneumonia. WBC is inflammation. I started by saying that it could be inflammation, could be infection. So WBC. So you add a WBC here. Okay, you add a WBC here. Now you come to clinical features. Clinical features, what are you coming as? Clinical features, what you are seeing. This is what you are getting.
Respiratory.
Symptoms, okay. Huh? Or here one more thing will come. WBC and one more thing. What is the other? Cough, cough, cough. Inflammation, no? Cough. The patient is coughing on the ventilator.
Clinical features में नहीं आ रहा cough.
Cough is inflammatory features. I'm just trying to make it easy for you. When you are inflamed, you will basically cough. When you are inflamed, your WBC count will go up. When you are inflamed, you will get a fever. I'm just trying to make this simple for you so that you don't have to think too much in your exams. You understand? So put it as inflammation as one side, and the other is what do you see? What do you see?
Tachypnea.
What do you see? This is already come in this. What do you see as clinical feature? What you said initially?
Secretions.
Secretions. Okay, so what you see is secretions. Specifically, we are going to specific topics. Tachypnea, tachycardia, these are all there. But specifically for ventilator associated pneumonia, what are you going to look at? You're looking at the lung, right? So with respect to the lung, these are the specifics that you're looking at. Okay, so what you're looking at? Sputum. What is the characteristic you're looking at? Sputum. Sputum either increased volume, change in color, or increased requirement for secretion drainage by mucus by subglottic secretion, subglottic drainage or endotracheal suction. So what are you looking at? So either a sputum volume that is increasing, a sputum purulence that is occurring, or it could be the presence of this patient receiving
कितना लगे?
हाँ? अभी कर देते हैं।